Welcome everyone. Okay, let me click OK. So welcome to our April GloCal Career Development Series. And today I'm really excited and we're fortunate to have Dr. Annick Borquez. And she is one of our steering committee members for GloCal. So she's done a lot of contribution in terms of interviewing all the wonderful fellows. And so really great to have her here today. So before we begin, I'll just make a quick introduction. And then, as before, I think if we can have some time in the end to have space for a question and answer, that would be really great. Um, so Dr. Annick Borquez is an associate professor in the Division of Infectious Diseases and Global Public Health here at the University of California, San Diego. She's a substance use and HIV epidemiologist focused on the health of marginalized populations, including people who use drugs, people experiencing homelessness, transgender women, and sex workers. Um, Annick's research focuses mostly on the US and the US-Mexico border region, but she also collaborates closely with colleagues in Peru, Brazil, and the UK and Australia. She just mentioned that she just came back from Brazil. She uses mathematical modeling and qualitative research methods to investigate risk and epidemic dynamics of HIV and overdose, as well as to retroactively evaluate and prospectively estimate the potential impact of structural treatment and harm reduction interventions to reduce their incidence. So it's such a wonderful treat to have her here today, and I am going to turn the floor over to Dr. Borquez, and she can share her wisdom with us.
Thank you so much, Dr. Lee. I'm really glad to be here and to meet all of the GloCal fellows. I hope everybody's doing well. Here is hopefully my presentation. So I'll skip the introduction since it's already been covered. So my plan, I'm just going to tell you about how I'm going to do this, and feel free to interrupt me at any point to ask questions. I basically organized it in terms of education, so just so that you know where I've been, and given that I've been asked to focus on funding, at each stage I'll tell where I got the money from, because we all know that it's important when you're in academia. So I'll try to remember that, and then I'll tell you about my main research areas. So the research areas are not necessarily chronological. It's more, I've tried to separate it by topic rather than chronology, because as you know, some things keep going for many, many years, while others are just, something that you do for a period of time. So that was the idea. And yes, please do feel free to interrupt me. So I'm French Mexican, and I was born in France, but we moved to Mexico City when I was very, very, very young. And I did all of my schooling in Mexico City, but in a French school, which meant that when I finished high school, I had the diploma, the baccalaureate, to actually study in France. And the French system is free, so you barely pay anything for education there. And there's lots of support for students in terms of accommodation, and even getting, like transport, food is very, very cheap for students. So I moved back to France when I was 18 to study, and I was in Lyon, which is in the center east part of the country, just in front of Switzerland. And there I did a technical degree. It was just 2 years, and it was biological and biochemical sciences lab technician degree. Basically, I didn't know what I wanted to do with my life, and I thought I'll do something that's very short, that gives me a job when I come out of there, and that way it gives me time to think or figure out what I want to do, but I'll be able to support myself. And so after doing that, I ended up going to Scotland, to the University of Edinburgh, for the 3rd and 4th year of biology. So I studied this kind of like lab technician degree in France, and it was very much focused on microbiology. And so I ended up doing a BSc in microbiology in Edinburgh. I don't know why my slides are no longer advancing, but I'll use this one. And so that was a bit of a shift, because it was much more of a less focused this was very much focused on technical skills and, you know, how to grow bacteria, how to do experiments properly, whereas in Edinburgh, it was a much broader, you know, kind of program in terms of what biological sciences covers, and even in the field of microbiology, it was broader, and that's when I was exposed to epidemiology. And I had always been very interested in social issues. I actually even thought that at some point, you know, I applied for journalism schools, and so I felt epidemiology was a perfect mix of biology with all of the social issues that influence disease. And so that's when I moved to London in England, and I studied a master's in modern epidemiology. That's what it was called at the time, at Imperial College London. And the reason it was called modern epidemiology was because it had a very strong focus on mathematical modeling. So the Department of Infectious Diseases Epidemiology at Imperial College is very much focused on mathematical modeling, and they are the ones who advise the WHO when there's a big outbreak of Ebola, for example, or during COVID. They were extremely involved in informing public health policies in terms of closing borders and you know, lockdown policies, etc. So the reason I ended up doing my master's there was based on advice from the epidemiology lecturer that I had in Edinburgh, who said, well, you're very lab-based and microbiology, biology-based, and you don't have the statistical skills that are very important to the field of epidemiology. And so given that Imperial College is very maths-focused, he advised that I go there. And so I ended up doing a lot of mathematical modeling, which was absolutely not my intention at the beginning. I actually wanted to do qualitative research, and I've kept wanting to do qualitative research for the rest of my life, and I'm now finally doing it, but it's taken me over 15 years to get back to what I wanted to do, because the field of modeling is relatively small, so there's a lot of demand for modelers, and it's always an interesting method to incorporate into a grant. And so you always end up being aim 3 of the grant, which basically takes the information from the other aims and actually looks at the potential impact of the intervention or evaluates the intervention. And so it provides more of a broad picture and more of a policy-oriented kind of piece of information that is valuable in grants. So I very much focused on HIV among populations, among key populations in Latin America during both my master's and my PhD at Imperial College. And yes, and I'm going to talk about this a little bit more in a minute, but I also was working very closely with UNAIDS, because the Secretariat for the UNH reference group in modeling estimates and projections was based at Imperial College. And my supervisor at the time was the director of these secretariats for the research bit. And so they are the ones who are able to say there are 40 million people infected with HIV this year, X many people are receiving treatment, etc. So to produce all of those numbers, there's a lot of models behind, and this reference group coordinates all of the work that's done to actually produce those models and change the methods as we learn more about limitations, etc. So I was very much working with Imperial College in collaboration with UNAIDS during those years. And then after doing my MSc, PhD, and postdoc at Imperial College in London, I actually spent 9 years almost at the same desk. I moved to San Diego, that was in 2015, to do a postdoc that was more focused on HIV, but focused on substance use epidemiology. And the intention there was that I wanted to do more field work, that I wanted to be closer to the participants and to the populations that I was investigating. And that was very hard at Imperial, because it was very much a data center and they were focused on methods development. And we almost always used data that was collected elsewhere. I was also very much wanting to be closer to Mexico, because I had been away for about 14 years by then. And so San Diego was a good option in terms of working with Mexican data, but still being kind of connected to a more international research network. In terms of funding to join UC San Diego, I applied for several grants before coming, and I got NIDA International Fellowship, which I'll provide a link at the end of my presentation. And that covered about a year of my salary, but it wasn't enough to actually cover what UCSD pays. And so I had another funding from a collaboration between the University of California, San Diego and CONACYT, which is basically the Mexican NIH. And I also got a top up from a CFAR international pilot grant. And so with those 3 grants, I had enough funds for a year and a half of salary, which kind of gave me a little bit security in terms of like leaving the UK and moving abroad. Before I start talking about the research, I thought it might be worth giving you a very brief overview of what mathematical modeling is, because I have been doing a lot of work using mathematical modeling, and many of the papers I'm going to be introducing are using mathematical modeling. So it's basically a method to simulate individuals, their behaviors and their contacts over time, leading to the transmission of infectious diseases. And so the difference between statistical models and mathematical models is that statistical models describe associations between a variable and the outcome. So in this case, it would be infection, whereas mathematical models actually reproduce the mechanisms of transmission. And so it's going to reproduce sexual contacts or sharing of injecting equipment and the probability that a person gets infected during that contact, and then the spread of infection through the population. And so it's very much describing the development of the epidemic through time in a population. And so it's possible through modeling to look at real world scenarios in terms of like what would happen if we implemented this intervention, how would the course of the epidemic change, or what would have happened had we not implemented this intervention. And so that allows you to evaluate what proportion of infections might have been averted by that intervention. And there are 2 main types of models, individual or agent-based models, and that's a bit like SimCity if you've seen that one. And basically each individual is represented, and when they get infected and they infect other people, all of those processes are represented in the model. And there are also deterministic models, which basically group people together based on certain characteristics. So if we're talking about infection status, we will have people who are susceptible. So in this case, for example, the people in blue in the individual-based model were susceptible. Here they would all be grouped in one compartment. And then there's a certain rate of becoming infected, and people move into the infected compartment, and then they move into the recovered compartment. So here it's basically the people in red would be all brought together into the I compartment. And then we don't have anybody immune in the little graph that I'm showing here, but basically it would be the same. Like when those in red become immune, they would move into the R compartment. So that's just a way of making models much simpler in terms of computational, computational workload. So recently, it's been easier to implement individual-based models because computers have obviously evolved. And so there's more of a move towards agent-based models, but they also require much more data in terms of contact between individuals, etc. So it basically depends on whether you have social network data, if you decide to do an agent-based model or a compartmental model. I've mostly focused on compartmental models through my career, based on data availability. So I was telling you about UNAIDS and the work that I did with them. So this was very much within the scope of their Know Your Epidemic, Know Your Response initiative. And as I said, there's this group called the Reference Group in Modeling Estimates and Projections, which basically develops the methods to produce these estimates. And so there's a whole range of outcomes that they're interested in. And so it's not only the number of people with HIV or the number of people who are receiving ART treatment or who might be orphaned as a result of HIV, but also they want estimates to inform the response. And so one of these models was called the modes of transmission model. And what it did was that it estimated the distribution of new HIV infections in the next year by exposure. So, for example, I'm going to start with this one. Basically, it divides the population into groups based on their exposure to HIV factors. And so it has all of the key populations, so men who have sex with men, female sex workers, clients of female sex workers, people who inject drugs, and sexual partners of people who inject drugs. The low-risk heterosexual population, which is mostly people who've had one partner in the past year, people who engage in casual heterosexual sex and their partners. So these are people who would normally be classified as low risk, but because they are partners of people who are having casual heterosexual sex, they kind of have a higher risk of exposure. And then people who are at no risk during that year because they didn't have any sexual or injecting contact. And we were also considering HIV transmission through blood transfusion and medical infections. And so injection, sorry. And so this model was used for many years across multiple countries to identify which groups would bear the burden of incidence in the next year. And so the idea is that if you know where infections are most likely to happen in the next year, you are better informed in terms of where should I allocate my resources and how should I implement interventions to prevent these infections from happening. This model was very simple. It was implemented in Excel, and it meant that countries could actually do it themselves. And we had several meetings in which international consultants from the reference group and other research groups would go to the countries and help the national consultants implement that model, find the appropriate data, check that everything was working. And so I did this for several years, supporting countries in implementing this model. But when I was doing the postdoc, the goal was to actually improve this model, which had lots of limitations. And so I developed an alternative model, which was called the incidence patterns model.
These guys fuck behind.
I think somebody needs to mute their. Great, thank you. So yes, I developed this model, which actually addressed all of the limitations of the modes of transmission model, which was very simple, but actually had quite a few issues, which led to some estimates being quite inaccurate. And so the main advantage of this new model was that it also divided the information by geographical location. So you can see here, each column represents a different province, and the width of the column represents the number of infections. The proportion of infections in each of these different administrative divisions. And each of the colors represents a different population. So it basically was very much doing what the modes of transmission model was doing, but addressing all of the methodological limitations and also providing this information by geographical location so that countries could know which part of their country would be most affected and could implement interventions. Then during my PhD, I did a lot of work on PrEP because in 2010, 2011, the first study showing that PrEP was efficacious in reducing HIV incidence among men who have sex with men and transgender women became available. And so it was the first time that we had another prevention method that wasn't just condoms and that could actually help us reduce HIV incidence among a population that was experiencing a very high burden in several countries. And so the IPREC study, which was a study that showed that PrEP was efficacious among MSM and transgender women, was implemented in Peru and several other countries, but the bigger proportion of the sample came from Peru. And so we were collaborating with Peruvian colleagues at the time, and we decided to take the data from the IPREX trial to actually look at not only efficacy of PrEP, but effectiveness of PrEP if it was implemented at population level. So if there was a PrEP program that was implemented in Peru among men who have sex with men and transgender women, what would be the impact and what would be the cost effectiveness? And so this was the first study to estimate impact and cost effectiveness of PrEP among an MSM transgender women population in a low and middle income country. And so this was all based on data from the IPREX trial with several assumptions in terms of how people would be adherent to PrEP in the real world, right? It was kind of, we had to do some sensitivity analysis, etc., because we only had information from the trial at the time. And basically, I mean, I'm not going to give you a class of modeling at this stage, but it was very much about describing sexual behaviors among the MSM and transgender population. And so here we divided them into 4 groups because these 4 groups were quite different in terms of behaviors and in terms of prevalence of HIV. And so we had this group, which are men who have sex with men who identify as homosexual. And so each is divided by sexual positioning. So we have men who are mostly insertive, men who are mostly receptive, so top, bottom during anal sex, and also those who engage in both receptive and insertive anal sex. And we have MSM who self-identify as either bisexual or heterosexual. And in this case, we considered those who are mostly insertive or versatile because there was a very small proportion who reported being mostly receptive. And then we had men who engage in sex work, and then we had transgender women. And for transgender women, because the vast majority reported being mostly receptive, we only considered that sexual positioning for them. And the arrows represent sexual mixing between the different groups. And so that's what we were representing in order to accurately describe the epidemic among MSM and transgender women in Peru, and then on top of that model of HIV transmission, implement the PrEP intervention and estimate how many HIV infections could be averted in the future through that program and how much that would cost. I've also did a lot of work focused on transgender women only. This was first as a result of a big review that was done on sex work. It was a special issue on sex work that was produced by The Lancet a few years ago, and I was part of this group. We did a little mathematical modeling component just to look at the potential impact of these interventions in 2 different settings. That was San Francisco and Lima in Peru again. And so then I further developed that study to actually inform HIV prevention among transgender women in Peru. This was also a strategic choice because at that point, Peruvian colleagues were very much trying to get a plan for HIV prevention among transgender women, specifically in Peru. And so far, there was no special plan for transgender women. It was just key populations, and they were brought together with MSM. And there were lots of issues with that because they weren't receiving the services that they needed and that they would benefit from. And so this was in an effort to support that initiative. And actually, a couple of years later, Peru approved the plan for prevention among transgender women in order to clearly describe what had to be done to reduce HIV burden among this population in Peru. And so this collaboration has continued. Recently, they just finished the IMPREP study. This was a demonstration project that was funded by UNITAID and that basically implemented demonstration projects in public health systems or NGOs in 3 countries, Brazil, Peru, and Mexico. I'm saying Brazil first because Brazil was the leading country in this grant. Brazil incorporated PrEP within their public health system in 2017, meaning that people can get PrEP for free since 2017 through the public health system in Brazil. And so they were already quite advanced in the process of PrEP implementation. And then Mexico and Peru, which were much later in the process, but Peru had all that research experience with IPREX, and they have had a very strong research program with MSM and transgender women through time. And Mexico had less experience, but also had a strong HIV clinic system, at least in Mexico City. So it made it possible to compare these 3 countries. And the main goal of this project was to actually support PrEP implementation across the region, so across Latin America. So it was looking at 3 countries with different public health systems and basically seeing what the implementations issues might be, etc. So as I said at the bottom, it's like supporting a South-South collaboration for knowledge exchange and dissemination. And so it enrolled over 9,500 MSM and transgender women between February 2018 and June 2021. And basically, I've been in charge of the mathematical modeling component of this grant to estimate the real-world impact of PrEP implementation and also cost effectiveness. So this is just to give you a very brief outlook of all of the components that are considered in this study. And so mathematical modeling, which is number 5 here, is just one component, but they were looking at PrEP delivery, PrEP awareness. They measured seroincidence to ensure that we were actually providing PrEP to people with high incidence, so in need of PrEP. There was also a qualitative study to better understand patterns of adherence, etc. And also in the scope of HIV among transgender women and PrEP and prevention among transgender women, I'm currently collaborating. I'm a co-investigator with the ENCORE study, which is led by Johns Hopkins. And basically, it's a national cohort of transgender women across the United States. And it's following transgender women for 2 years, asking them about behaviors, but also structural risks associated with HIV. So employment, violence, discrimination, housing, to better understand how these risks influence HIV acquisition among transgender women. And so this is just a little bit about, of information about ENCORE. And so it's a digital cohort, but it's supported by 6 city hubs, and San Diego is one of them. So in the city hubs, we're able to actually engage with potential participants and help them fill in their survey and help them do their HIV test. And this is to ensure that we also are able to measure differences between women who who recruited online versus those who recruited in the community, because there are differences generally between the two groups, and only recruiting people online might mean that those who don't have internet access or low internet literacy are not represented, and that we might have a biased representation of the population. So very briefly, these are the aims of the grant. I'm not going to go through them all, but in general, it's basically characterize patterns of syndemic experiences among transgender women, estimate HIV incidence, and then I'm in charge of the mathematical modeling component, which is estimating the impact of potential interventions in the United States, looking at different combinations to see what would be most strategic and most effective. And so this is just to show you the sites, the city hubs. And as you can see, San Diego is the only one west of the Mississippi. And so we're trying to get as many participants as we can to have more of a representation of what's happening on this side of the country. So a lot of the work I've been doing, and this is shifting from HIV among transgender women to more HIV and other health harms among people who use drugs. Once I moved to San Diego, my work was very much focused on HIV among people who inject drugs in Tijuana, which is the bordering city with San Diego, and it's on the trafficking route. So there's a lot of spillover effects, and there's an important problem with opioid use in Tijuana and very low access to care. So I've been working with that population, and there's been a strong focus throughout my career in looking at the contribution of structural determinants of health as opposed to just behaviors, right? So you've probably seen this diagram many times, and there's many variations of it. It's based on the social ecological model, but this was specifically focused on HIV. And so it talks about transmission dynamics influencing HIV acquisition, but on top of that, you have behaviors, and on top of that, you have the social factors that influence behaviors. And on top of that, you have the structural factors that influence these social factors, and then the whole causal pathway towards HIV. And so in this particular case, when I came to San Diego, I was focusing on the drug law reform in Mexico in terms of how it might influence HIV among people who inject drugs. So I've circled here legal structural factors. And so it's how laws and policies actually influence risk among people who who use drug in this case. And so there's been several countries implementing drug law reforms in the past 5 years as a result of an acknowledgement that the war on drugs and criminalization hasn't been effective, especially in the health component of the drug problem. But there has been a lot of lack of monitoring, a lack of evaluation, and lack of dissemination of information around these drug law reforms. These are political initiatives that are implemented in countries, but they're often not linked to it with research. And it's really important to actually document which reforms are successful versus not. Especially in relevant, this is especially relevant in challenging settings where information might be less transparent, which is the case of Tijuana in Mexico. And so very briefly, the reforms in Mexico depenalize possession of a selection of drugs for personal consumption. And so the expectation was that this would decrease incarceration rates and police harassment. But it also mandates drug treatment at the third apprehension. And so it's considered that if you're apprehended 3 times with a certain amount of drugs for your own consumption, you have a problem with substance use and you need to receive treatment. And so that this would also increase treatment rates. It was meant to be enforced from 2012, but I mean, when we did this study, it had not been implemented properly based on our work in Tijuana. And so the goal of this project was to actually produce scientific evidence of what this narcomenudeo reform was actually, was actually doing in terms of health among people who inject drugs. So again, I developed a model that looked at incarceration because we wanted to see what would happen if incarceration rates were reduced, and that also looked at treatment. So you can see treatment here at the bottom. I'm trying to find my, here it is. So we had 2 types of treatment, compulsory abstinence programs and opioid agonist treatment. And so the hope is that people will receive evidence-based treatment, which is opioid agonist therapy. But the reality is that in Tijuana, most treatment centers are compulsory abstinence programs, which have been shown to increase health risks. And we were also looking at syringe confiscation because this is a big problem in Tijuana, and it actually leads to increased syringe sharing among people who inject drugs. And so this is basically a description of how the population is divided in the model. I assume it's not very straightforward to understand when you're not, familiar with compartmental-based model, but it basically tells you that the population is divided by sex, by incarceration status, by syringe confiscation status, so whether they are exposed to syringe confiscation or not. And then we have all the stages of HIV infection, so people moving from one stage to the other once they get infected. And so basically, as I said, statistical analysis inform mathematical models. So we were looking at the association between incarceration and HIV infection, so HIV prevalence in this case. And we had information about like the increased risk of HIV. Sorry, I'm saying it all wrong. It wasn't HIV as the outcome because the prevalence of HIV is about 4% in Tijuana, and so power was low to actually look at that. And ideally, we would have looked at HIV incidence as opposed to prevalence, and that means that the sample size is even smaller. So instead of looking at HIV as the outcome, we were looking at syringe sharing as the outcome. So whether exposure to these factors increases the risk of syringe sharing, which obviously increases the risk of HIV transmission. And so there was a significant risk of syringe sharing among those who had been recently incarcerated. And there was an indication that this was still true when the incarceration wasn't recent. So this was among those who had been incarcerated in the past 6 months. And this was among those who had been incarcerated, but not in the past 6 months. We also did this for syringe confiscation and found, again, a significant association syringe confiscation and syringe sharing. And we also did this with involuntary treatment, which is basically these compulsory abstinence programs. And we also found an increased risk of syringe sharing. So all of this information was brought into the model. And so here you're modeling the baseline epidemic, and then you're saying, well, what would happen if we eliminated incarceration? And so this is what we did. And then you run your model again, you obtain a different epidemic, and you're able to calculate the difference in new infections over the period of time that you're interested in representing. And so this gave us, this quantified the contribution of incarceration and syringe confiscation to HIV incidence among people who inject drugs in Tijuana between 2012 and 2030. And so you can see that both incarceration and syringe confiscation was estimated to contribute to about 10% of new infection among this population. And then we also looked at the reform and what the expected impact of the reform would be. And so if the reform only helped in terms of reducing syringe confiscation, which seemed to be happening in Tijuana, we would be looking at a reduction in new infections of 5%. If it also led to a reduction in incarceration, we would be able to eliminate about to prevent about 9% of new infections. If the program was actually linked to treatment in compulsory abstinence programs, it could actually increase HIV incidence as a result of the increased risk of sharing when coming out of these programs. But if OAT, so opioid agonist therapy, was provided instead of these non-evidence-based programs, then we could reduce about 1/5 of incidence by about 1/5 in those years. And so this was basically saying, if a reform is implemented properly, it can lead to a substantial reduction in HIV incidence. But if it's not, then it might actually be counterproductive. I'm gonna hurry up a little bit because I want us to have time for questions.
Yeah, so Annick, just a time check, we have about 20 more minutes. So I think if you have lessons about funding issues that you mentioned earlier, I think it will be really helpful to, have time for our fellows to ask questions regarding those as well. So
Yeah.
just wanted to provide you with, I think we have about 20 more minutes.
Great. Yes. I mean, I just need two more minutes for this section, and then I'm going to be talking a little bit about funding. So this is just to tell you about the research that I've been doing more recently. So this got funded by a NIDA Avenir grant. And so that's one of the very few that are available to non-US citizens or non-permanent residents of the US. That was a massive problem for me when I came to the US because I was a postdoc and not a citizen. And it means that you have very limited access to funding. And so I'm going to be talking about that. But basically, this grant looks at predicting drug-related harms in the US. And so this is basically showing that, I mean, as you know, we've had a very severe overdose epidemic in the United States. And the idea was to transport some of the work that we've done in the field of infectious diseases and HIV in particular, in terms of better understanding the dynamics of the epidemic, in order to anticipate where the problems are gonna, where it's gonna hit harder, and actually prevent it. And so as part of this work, we produced a model that actually predicts fatal overdose rates in the next year at county level across the entire United States. And we developed an app that allows to compare what the model predicted versus what actually happened. And we also produced repository with all of the data that's needed to implement this study to help other researchers also produce similar models, so that we can have more of an evidence-based series of models. And so as part of this, we also developed machine learning models that actually do the same that our original model did, but in the hope that this would improve the performance. And so this is basically looking at the performance of these different machine learning models in comparison to our original model, which was a negative binomial model. And so these are, for example, the predictions that we have in terms of overdose, fatal overdose incidents in the next year, so in 2024, for the entire United States. So I'm going to skip this. And so we are now speaking a little bit more about, I'm I'm very briefly gonna say what we're doing in terms of another of my research fields is guiding harm reduction interventions. And there are several projects that I'm involved in. One of them is in San Diego and Tijuana, and it's basically characterizing the impact of changing drug markets and cross-border drug use on health among people who inject drugs. We're also looking at overdose response using naloxone among people who use drugs in Reno, Nevada. So that's another project to better distribute and support people in terms of using naloxone so that we can reduce overdose incidents. And there's a big naloxone expansion program happening in San Diego, and we're helping to evaluate this. And there's also a drug checking service that was implemented about a year and a half ago in San Diego, and we're helping enhance this one. And I also just very briefly wanted to speak about community engagement. This is something that has been very important for me, and I think for people who are working with marginalized populations, it should be incorporated in your research as early as possible in terms of building collaborations with organizations who are working closely with these populations. And so I've been doing quite a bit of work in terms of engaging people with lived experience in your research. And this is not very commonly done in the field of modeling because of it being so technical, but it's actually very important to have a realistic understanding of risks among this population when you're modeling the epidemic. So, and yes, so the important topic here in terms of funding options, I'm focusing on non-US citizens. I know that some of the GloCal fellows are US citizens, but I wanted to talk a little bit more about this specific case when you're not a citizen, because it's harder to find options. And so I mentioned the NIDA International Fellowship initially. I've provided the link here. Mine was focused on Mexico, the US-Mexico collaboration, but there's also one for France, and there's another one. They're all there. So hopefully you'll have access to these slides and can have a look at the link. But that's the one that provided me with about a year of funding that then had to be topped up. There's also local collaborations between US universities and home countries. So in my case, for example, there was a collaboration between the University of California and the CONACYT, which is literally the Mexican NIH. So it's actually quite hard to find out about these smaller grants and smaller initiatives. And in this case, it's very important to be in contact with a mentor who's worked in that area for a long time, who's supervised students and postdocs in the past, and who's helped them transition to faculty, and who's identified all of these different pots of money and sources of funding. So that's why the GloCal Fellowship is so valuable in that sense, that it allows you to build your network and to be in contact with people who might be much more aware of these funding opportunities. The CFAR is a great source of funding, especially in terms of giving you a way to produce preliminary data and have proof of international funding. And so, for example, the CFAR International Pilot Grants, they're small grants, they're about $40,000. But they're considered, international funding, they're NIH funding, and it allows for a collaboration between the home country and a US university. And so for people who are at the postdoc level like you, it's a valuable way to, if you get an assistant professor position in your home country, you're able to apply for these grants. Once you are in the US, but you don't have US citizenship or permanent residency, the options are quite limited in terms of NIH funding. There's a K99R00. You have to have less than 4 years of postdoc experience to apply for this one. It's very competitive, but it's an interesting grant because it gives you 2 more years of funding as a postdoc, and then you transition to an assistant professor position, and it gives you 3 years of funding in that role. And so it's called R00 because it's basically the step before the R01. It's like a mini R01 that you get at the end of that grant in those last 3 years. But basically you're competing against all people who don't have US citizenship or residency. Another source of funding that can be helpful, at least in terms of giving you a step inside the system to then kind of keep moving forward, is administrative supplements. And those are not limited to people who have a faculty appointment. So in the same way as the K99, it's open to postdocs. And so again, it's important to have a broad network so that you can apply for administrative supplements on these big parent grants, such as R01s. And they're generally about $100,000 and they last 1 year. The CDC doesn't limit application to faculty who are US citizens. So in the past, I have applied for CDC funding when I was a postdoc. My advice would be, if you do this, to be co-PIs with somebody who's faculty in a university to kind of strengthen the profile of the grant. But basically, it doesn't, yeah, it's allowed. And it's one of the few ones where you actually can do it. And then the Avenir, which is the one I ended up being awarded. I have the NIDA one, but I think there's other NIH agencies that have the Avenir. It's a little bit equivalent to an R01, but they're very focused on novel ideas and high-risk projects. And so it's about thinking of something that might actually derail the course of research in that field. And it's a relatively easy application to write because it's much shorter, but it's very focused on the idea and how you sell that idea. And I also wanted to highlight the CFAR newsletter shares funding announcements regularly. So if you can get onto that newsletter, you can ask your mentors. They're obviously focused on HIV. So if HIV is not your field of research, it might not be as helpful, but it might at least give you an idea of the different types of grants, and you can search for similar types of grants within your area of research. In terms of grant writing resources, I very much recommend taking grant writing courses. There's good ones from the NIH and from the University of California. Each university and even sometimes each department has their own courses. So I decided to keep it very simple, but ask for these among your colleagues or mentors, because they are, it's basically, you have to be very strategic when you're writing a grant, and these courses provide you with that strategy and tell you about timelines and the different components so that it's less overwhelming once you come to actually doing it. There's also the CFAR OK review. Again, it's supposed to be focused on HIV topics, but they are actually quite open to non-HIV grants as long as they are focused on marginalized populations, for example. And it's basically a mock NIH section. So they sent your grant to a few reviewers, and then they discuss it, and you are present during the discussion, and you can see how a grant is actually discussed at the NIH. Is very brief. It's only 15 minutes, and it makes you understand why you have to be so clear when writing a grant, and why you have to keep it so simple, because many of the reviewers are not experts in your field. They might actually be in completely different fields and have absolutely zero background knowledge about what you're writing. And so it's hard to understand, and it's very difficult to detach from the detail, but it's very important to keep it at a level that can be understood by most researchers, and to keep it very clear, because people are reviewing multiple grants. They don't have time. And if they start having doubts and being confused, then it's very likely that they'll have a bad impression of the grant. And so it's important to experience this process and to be present at a review section to have a better understanding of what's happening. But of course, they also give you advice about your grant, about what to change. And so it's a very useful process to go through, especially when you're about to submit a grant and when you're early on in the grant writing process. Although I think it's always a good idea to use these initiatives. It's very useful to look at other grants. I think that's probably the most useful thing that you can do. Just ask people to share successful grants with you, understand the structure of the grants and how people have made it compelling in terms of a research project that must be funded. And I also advise you to check the NIH Reporter, which is basically the repository of the NIH in terms of which grants are currently funded and have been funded in the past. And you can search by topic, you can search by researcher, but if you do it for your own topic, when you're in the process of planning an idea for a grant, you can see everything that is currently funded and has been funded in your research area. And it gives you a sense of what the NIH is interested in and what's already funded, and so you might want to do something different or complementary. I should also say that it's important to look at NIH priorities, and I didn't include that bullet point here. I should have, but always look at your agency's priorities, and that's a web page that should be really straightforward to access, and they generally are updated every few years. So when you're writing a grant, always say, this addresses NIDA's priority of blah, 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 blah. I'm nearly done. This is my last slide. Just tips for academia. I think it's very important to build a network of mentors and collaborators. We're very much used sometimes to following only one person, but this actually limits your possibilities in terms of being included in grant proposals, in terms of being included in papers, in terms of developing new skills. So it's important to have a few people that are, serving their different purposes and that are helping you in different ways. I also think it's very important to develop a specific expertise that people search you for, that people basically need your input in terms of, so in my case, for example, it was mathematical modeling, and it's opened several doors in terms of participating in a range of projects. But I also advise to explore and get involved in projects that are, different from what you normally do, because sometimes it can lead to whole new fields and to whole new sources of funding. Important, learn to tell a compelling story. As I said, reviewers are reading many grants and they want to be excited. So at the end, it's a very human behavior that's behind this very structured and rigorous review process. It's people at the end of the day who are reading your grant, and you want to make them feel that it's going to change something. As I said, keep it simple on the grant, but rigorous on the paper. So I think sometimes we forget that step, and we have a tendency to oversimplify everything. But I think we have to remember that once we're doing the work, we actually want to do it rigorously. And I provided you with a research here, which is a National Center for Faculty Development and Diversity. Normally with the UC, you have a free membership to it. And there's a faculty success program that you can join, and that basically helps you towards academic success, but also have better work-life balance. So how to protect your life, because academia is extremely draining, and it's important to put boundaries early on. And I'm stopping here. Hopefully we still have about 5 minutes for questions.
Yeah, we got, let's see. Yeah, we got a few minutes. We got about a little less than 5 minutes. So, well, thank you for sharing your work. And this is our time for our fellows to ask questions. So you can either unmute or type it in the chat. So please go ahead. Questions for Dr. Annick Borquez. So I think in the few minutes, I wanted to pose a question about, I think in terms of, one of the lessons that you provided is developing a specific like content expertise. So I think in your case, I think it's really powerful to and work with, the team of scientists who are working on all these different issues. So I guess, wanted to hear your comments about, so like fellows who are in HIV, but also working on other fields, other content areas. So wanted to kind of hear your thoughts about that.
Yes, I mean, if I'm completely honest, modeling for me has been a two-sided story, because it has kept me employed. It has, opened doors to very interesting projects, but it's not really what I wanted to do. I really wanted to do qualitative research, but you end up kind of following whatever keeps you employed. It's a difficult, it's a difficult environment, but I must, I also have to be very yeah, to acknowledge the fact that when you have something very specific to offer and people know you for that, then you know, it's easier to get involved in projects and to get funding. And so, for example, if you come from another field and you have a technical expertise in a lab technique, for example, you know, I've read several GloCal fellowships that use the GloCal program to learn a specific technique in terms of cellular, I mean, I can't remember right now, my brain is a bit blurry, but that's very powerful because you might end up being the person who knows how to implement that technique or implement that statistical method. But also it doesn't necessarily need to be a methodological expertise. It can also be a topic, right? So if you are the person known for being the expert on leishmaniasis in you know, the whichever region, then so it's also about learning to tell your story in different ways. And I think that's a strategy that is very useful in the NIH system, right? That you can present your career in different ways. And so I'm seeing a few questions.
Yeah, so we have 2 minutes and we have 3 questions. So maybe
Okay.
you can review them and then share your thoughts.
So if you would like to become an expert in modeling, so there's a course at Imperial College that's a 2-week short course that's very, very good. And they offer scholarships to a small number of people. And so I think if you just look for a short course in mathematical modeling of infectious diseases, the London School of Hygiene and Tropical Medicine also has one. So, I mean, this is UK, but there's also one at the University of Washington in Seattle. So that would be a more local, so that would be in terms of courses. They're very effective, they're very intense, and they kind of get you to also know lots of experts in modeling that you can then collaborate with. At UCSD, we have a course, an introductory course that we often welcome people who are not registered in courses to attend. So I'm happy to talk more about that with you offline.
Yeah, feel free to contact Dr. Borquez if you
Yes,
have additional
please do. And
questions.
I should have put my email, but I'll put it here. And the other one was, oh, that an objective on mathematical modeling boosts the application somehow. Yes. Yes, basically because it brings it all together and it tells you, okay, if we implement this intervention, what would be the impact? How should we implement it? And so it's a very attractive way to show the policy implications of all the work that you're doing. So I do recommend contacting a modeler and bringing them into your grant to add a name. And then...
Yeah. So Dr. Annick Borquez has provided her email address here. So I know that we are right on time. So I encourage you to, if it's okay, maybe they can contact you offline if they have additional questions.
Yes,
So,
please go for it and contact me. And if you also need help in terms of navigating the system to get funding when you're not a US citizen, I'm happy to help with that too.
great. Well, thank you so much. And thank you all for joining. And we'll reconvene in, I don't know, like next session, whether it's works in progress or career development seminar. So have a good rest of your morning, evening, afternoon.
Thank you. And good luck, everybody, with their projects and the GloCal experience. And congratulations for getting the funding. It's the first step.
Thank you, everyone.
Thank you.